Morning, everyone. My name is Mike Horton from the University of Leeds. I realise not many of you know me, so I thought I'd do a little introduction. I'm a research fellow and also a psychometrician. So for those that don't know what a psychometrician is, it's where we essentially try and measure something that can't be measured directly. So with distance, time, etc., you've got watches, you've got rulers. With things like symptom severity and long COVID, we can't just get out a ruler and measure that. So that's kind of what we try to do here. So I presented this work at the UK PROMS conference last week, which is patient-reported outcome measures, and I had some background about long COVID. I've cut that out because I don't think any of you need to know about that. So I'm briefly going back to look at the original C19-YRS, which is kind of what I'm talking about today. So this is all pre-locomotion. The original scale was developed primarily for use in clinics to try and signpost towards appropriate treatment pathways. And then kind of this was developed by Manoj and his team within Leeds. And like Manoj came to me and said, oh, can we use this as a functional outcome measure that we can carry on measuring people with? And that's when we kind of started to look at it. So the original C19 had two separate scales, one to look at symptom severity, one to look at functional disability. It also had an additional overall health item and then an additional symptoms list, which you can see had 6 items. When it says items, that means like questions. And all of the questions were scored on a 0 to 10 rating scale. So again, this is still prior to locomotion. We did some work with it, and we modified the original C19 using a combination of psychometric evidence. So we did some analysis and looked at how it was operating. And also, because long COVID was like still a very new thing, there was a lot of emerging clinical evidence regarding new symptoms, which weren't apparent when the original C19 was first developed. We also had some feedback from a working group of patients and healthcare professionals, again, about kind of new things that cropped up, which weren't covered in the original C19. So the modified C19 also still had 10 items in the symptom severity scale, but there were different. There was quite a lot of different items within there, like half of them had changed. The functional disability scale actually remained pretty much exactly the same. But one of the main changes was that the original 0 to 10 rating scale was collapsed down to a 0 to 3 rating scale because it wasn't operating how it was originally anticipated to work. We still have the overall health item, which is 0 to 10, and now the additional symptoms checklist, which is just a binary yes/no of symptoms, has been expanded to 25 named symptoms from 6 initially. So that's quite a broad list now, which is very useful within clinics. So the study aim was to kind of psychometrically assess and validate this new scale within a new population, which is using data collected from locomotion. And you probably won't be aware of this, but in the scale development world, this is quite unusual to be able to create the scale, modify it, and then revalidate it within a new sample. Usually it's like if you make a modification and that's it, and then it just like goes out for use in the general population, and you don't get this additional phase. So this is quite it's a nice situation to be in that we don't get very often. So using the LROS platform, I've seen Roman over there. We collected data using from all the locomotion clinics. This is workstream 2.2, and we got lots of data in, and we can use this to do what we want to do. And the psychometrics that we use is using something called RASH measurement theory framework, which is I'll go on to explain it a little bit, but obviously it is a little bit technical, but I will kind of glance over that. But it's a unidimensional measurement model where we're essentially just measuring one thing at a time in each of these 2 separate subscales of symptom severity and functional disability. That's the primary element. So the purpose of rationalysis is essentially to test the validity of a total score. So when we're adding up questions within a scale or questionnaire, we want them to all contribute to a single total score that makes sense. That's what we're essentially trying to do. So that's what we're validating within this system. And if there's any like anomalies to that measurement structure, we can highlight where they are and kind of how they're not functioning and feed that back to the developers, whatever. And it offers a unified framework to investigate lots of different elements of the scale at the individual item level, not just at the scale level, at the individual item level, which we'll kind of run through now. So just in brief, I've kind of set up a traffic light system here. I didn't put red on there because you can't see the red very well. So the orange is red, the yellow is orange, etc. So there's all the I'll put like the actual geeky stats in there, which probably won't mean anything to you. So just focus on the colours. Green is obviously good. Yellow is fine, and the orange is kind of the things that we like really need to focus on. But in general, this is the symptom severity scale, and overall, it was looking pretty good. We were pretty happy overall with how this was all functioning. And the same for the functional disability scale as well. There was not a lot there that we were not really happy with. So overall, it's generally looking all right. I'll focus on some of the other results now. So the good thing, first of all, the change in the response function. So first of all, it is a 0 to 10 across all of them. And we get these curves out for each of our individual items. Basically, what these are like implied probability distribution curves of basically where you are on the underlying trait, gives you a likelihood of responding in each of the response categories. So each one of these curves, each one of these hills should be emergent at some point as the most likely category. And the symptom severity in this case. So as you progress in terms of your symptom severity, you move from one category into the other in terms of which is the most likely response category. And then you get these transition points, which are called thresholds, between your response categories, and they should fall in this logical progressive order. So initially, for our original 0 to 10 scale, that wasn't happening for any of them. So if I just flick back to that, look, let's just say, look how nice the curves look. They're all kind of in order. And if you look at that top one there, that was the original 0 to 10, and you can see it was kind of like a mess. Because people, it's not that they don't know that a score of 4 is higher than 3, it's that they didn't necessarily know which one they were falling in. So they respond arbitrarily in like a 3 or a 5. And here it's kind of, it's saying that in reality, a score of 6 is not really operating any more than a score of 1. So that's obviously not what we want in terms of the total score with which we add up. So the middle plot there shows where we did like a post hoc rescoring of the original data to suggest that the 4 response categories was probably going to be better. And the bottom one is using the new data, using our actual prospectively collected data from the LOCOMOTION study to see how it did work. And we can see that actually it worked pretty well in terms of how we anticipated. So we were very happy with that. So in terms of the response category structure, the symptom scale on the left and functional disability scale on the right. Previously, there was nothing in there because they were all disordered. So each scale was completely blank because these plots only come up. So we were very happy with that, and we gave ourselves a little. In terms of the targeting, so targeting is how well aligned the scale is to where the people are that we're trying to measure. So what you should essentially see here is like a mirror image of one and another, and we can see that in both cases here, these are pretty good. So the top of the scale is where the pinky graph is where the people are, and the blue graph below the x-axis is where the actual measurement points are. These align pretty well with both the symptom severity scale and the functional disability scale. There's no big floor and ceiling effects. We're not missing out on a lot of data. We're measuring where we want to measure in terms of where we're. So we were happy with that as well. In terms of differential item functioning, which is a form of item bias towards a specific group, there was no evidence of this by gender, age group, or ethnicity. So again, we were happy with this in terms of our invariant measurement across these groups. The things that we need to look at a little bit more, they're not quite so good. This is where our anomalies lie. So the first of these, which were consistent, we split the sample to do a cross-validation across like an experimental and a validation data set. And the first of these is the cough max item in the symptom severity scale. So this is a combination of cough and throat sensitivity and change of voice. And this is ever so slightly sort of under-discriminating. So we can see the grey line there, that's what we expect, and the black dots are our actual data, and you can see that they're ever so slightly like flatter than the curve that we would expect. It's not a huge deviation, but it is outside of what we would consider to be a fitting item. So that's the cough max item. We found the same thing for the smell taste item, which is a combination again of altered smell or altered taste. And it's slightly under-discriminating, meaning it's potentially measuring something slightly different from the rest of the questions in the scale. For the functional disability scale, we had the same thing for the communication item. You can see that's a lot more pronounced in the validation group than it was in the experimental group, and still kind of an issue we need to be aware of. And we also had something called like local dependency, and that's where two questions are related more closely than they should be in terms of what you're trying to lie, what you're trying to measure. So for the symptom scale, these were fatigue and post-exertional malaise were kind of loading together, and breathlessness and cough were both loading together. Not enormously, but they were more than we kind of would want. And for the functional disability scale, walking and moving around was loading with personal care. All of these were relatively minor, and these dependencies do make conceptual sense. So fatigue and post-exertional malaise, you can see why they would load together. It's just a case of we need to report them to see how we consider within the scoring to deal with those, and that's kind of the information that we still need to gather from you guys and the patients, etc. So things that we need to ponder is why aren't these items working in the way that we want them to? Is there any logical reason why they operate in a slightly different way? I have posed this before at the LOCOMOTION meetings and also the sort of PAG group meeting that we have. And there was a bit of debate about it. I did offer kind of some suggestions, just like my own thoughts, but I'm not a clinician or a patient, so it was just kind of a bit random. And there was largely sort of disagreement between sort of patients and clinicians in that aspect. So we still need to ponder a little bit more. But also, does the clinical utility of the item of the questions within the scale, does it outweigh the psychometric result? And I'm going to say that it probably does, in that any changes that we do make will be kind of within the scoring rather than taking out the questions. I think we still need the questions to be there because of the information that they give us. It's just what we do with them with regard to like the total scores that we're creating. So in conclusion, some minor anomalies are apparent. Overall, we think that the modifications that we made to the original C19 actually have improved the scale, both in terms of measurement characteristics, clinical relevance, and conceptual relevance as well, in terms of the initial work that I did. That was everything.